Welcome to this lecture on hip, pelvis, and thigh pathologies. This region can be challenging because symptoms may come from muscle, tendon, bone, joint, nerve, abdominal, pelvic, or lumbar sources. So instead of memorizing diagnoses in isolation, we are going to organize the region by pain location, mechanism, load history, examination findings, and red flags. As we move through the deck, keep connecting each condition to sport function. Sprinting, cutting, kicking, squatting, landing, and single leg stance all stress the hip and thigh differently. The goal is to build a framework you can use in real evaluations. These objectives give us the roadmap for the lecture. We will review the major hip and thigh muscle groups, connect them to clinical actions, and then use that anatomy to understand common injuries and higher risk conditions. The key idea is that hip pain is broad. Groin pain is not automatically an adductor strain. Lateral hip pain is not always bursitis, and thigh pain is not always a simple muscle injury. By the end, you should be able to explain why location, mechanism, age, training history, weight-bearing tolerance, and red flags shape the entire evaluation. Use this anatomy overview as a regional map. Hip flexors, extensors, adductors, abductors, and rotators all influence femoral position and pelvic control. In sport, these muscles rarely work alone. For example, sprinting requires hip flexion, hip extension, hamstring control, pelvic stability, and trunk control at the same time. When an athlete reports pain, try to connect the symptom location to the structures underneath it, but also ask how that region functions during movement. Anatomy becomes clinically useful when it helps explain the athlete's task limitation. This slide organizes the major muscle groups by role. Hip flexors help bring the thigh forward during swing phase and kicking. Hip extensors and hamstrings contribute to propulsion, sprinting, and deceleration. The adductors help with groin stability, cutting, skating, and kicking. The abductors, especially gluteus medius and minimus, support pelvic control during single leg stance. The deep external rotators help control femoral position and posterior hip stability. When symptoms match one of these roles, that muscle group becomes part of the differential. Hip and thigh evaluation begins with a careful history. This region can receive symptoms from local tissues, but also from the spine, pelvis, abdomen, or neurologic system. Start by clarifying the exact location of pain. Onset, mechanism, training load, sport demands, weight-bearing tolerance, and whether symptoms are changing. Then let the history guide your exam. If the story sounds like a sprinting strain, resisted testing and palpation matter. If it sounds like deep groin pain with impact, your concern for bone or joint involvement rises quickly. For the subjective exam, ask targeted questions. Where exactly is the pain? Groin, anterior hip, lateral hip, buttock, posterior thigh, pubic region, or muscle belly? Did it start suddenly or gradually? Was there a pop, snap, sharp pull, collision, fall, or inability to continue? What provokes symptoms? Sprinting, cutting, kicking, squatting, stairs, sitting, coughing, or weight-bearing? Then screen red flags. In adolescents, think about apophyseal injury. In endurance athletes, think about bone stress risk. Night pain, fever, neurologic symptoms, or worsening weight-bearing pain should raise concern. The exam should match the leading possibilities from the history. Observation gives information about gait, posture, bruising, swelling, pelvic control, and stance tolerance. Palpation maps pain to anatomy, including the ASIS, AIIS, iliac crest, pubic region, adductors, rectus femoris, hamstrings, greater trochanter, and ischial tuberosity. Range of motion helps identify joint restriction or symptom provocation. Resisted testing helps determine whether contractile tissue is involved. Special tests and functional tasks refine the picture, but no single test should make the diagnosis by itself. This section focuses on muscle and tendon pathologies. These injuries are common because sprinting, kicking, cutting, jumping, and deceleration require high force and eccentric control. Use pain location and mechanism to organize your thinking. Anterior hip pain may involve hip flexors or rectus femoris. Medial groin pain may involve the adductors or pubic region. Posterior thigh pain may involve hamstrings. Anterior thigh pain may reflect quadriceps strain or contusion. The exam should confirm which tissue is symptomatic and whether any higher risk condition is being missed. Hip flexor and iliopsoas-related pain often follows sprinting, kicking, rapid acceleration, resisted hip flexion, or high-volume hip flexor loading. Pain may be anterior hip, proximal thigh, or deep groin. During the exam, assess resisted hip flexion, resisted straight leg raise, hip extension mobility, Thomas test position, palpation, gait, and functional loading. The important caution is that anterior hip pain is not automatically a hip flexor strain. Differentiate rectus femoris strain, iliopsoas irritation, AIIS apophyseal injury, intra-articular hip pain, lumbar referral, and femoral neck stress injury when the story does not fit a simple strain. Adductor-related groin pain is common in kicking, cutting, skating, and rapid change of direction sports. It often presents with medial groin pain, adductor tenderness, and pain with resisted adduction or adductor squeeze testing. However, athletic groin pain can have multiple contributors. The differential may include adductor-related, iliopsoas-related, inguinal-related, pubic-related, hip-related, or referred pain. Use clear terminology. Do not label all groin pain as an adductor strain. Assess hip range of motion, adductor strength, abdominal or inguinal symptoms, pubic tenderness, and functional cutting or kicking tolerance. Hamstring strain commonly occurs with high-speed running, late swing phase eccentric loading, overstretch, or kicking. The athlete may report a sudden pull, pop, or sharp posterior thigh pain with reduced sprint tolerance. Location matters because proximal tendon, musculotendinous junction, muscle belly, and distal tendon injuries behave differently. Examine palpation, bruising, swelling, resisted knee flexion, hip extension, length tolerance, gait, and eventually progressive running capacity. High-risk features include proximal tendon involvement, major weakness, large bruising, a palpable defect, or pain near the ischial tuberosity. Rehab should restore motion, progress eccentric strength, and reintroduce sprinting gradually. Quadriceps strain and thigh contusion are different injury patterns. A quadriceps strain is a contractile overload injury, often related to sprinting, kicking, jumping, or rapid eccentric loading. Rectus femoris is commonly involved because it crosses both the hip and knee. A thigh contusion comes from direct trauma and may produce pain, swelling, bruising, and loss of knee flexion range. With significant contusions, monitor severity and avoid aggressive early stretching or massage because of myositis ossificans concern. Examine palpation, knee flexion range, resisted knee extension, hip flexion, gait, and functional progression. Lateral hip pain may involve gluteus medius or minimus tendinopathy, greater trochanteric pain syndrome, bursal irritation, or lumbar referral. Symptoms often worsen with side-lying, running, stairs, single-leg stance, or positions that compress the lateral hip, such as hip adduction. The exam should include palpation over the greater trochanter, resisted abduction, single-leg stance, Trendelenburg observation, hip range of motion, and lumbar screen when needed. Do not assume isolated bursitis. Tendon load and compression are often part of the presentation, so management usually emphasizes education, load modification, and progressive hip abductor strengthening. This section shifts from common muscle injuries to higher-value differential diagnoses. Deep groin pain, catching, pain with weight bearing, night pain, adolescent bony tenderness, or persistent symptoms should broaden your thinking beyond a simple strain. These presentations may involve the hip joint, labrum, cartilage, bone stress injury, apophyseal injury, referred pain, or non-musculoskeletal pathology. The clinical goal is not to over-test every athlete. The goal is to recognize when the history and exam require caution, activity restriction, imaging, or referral. Femoroacetabular impingement and labral pathology often present with deep anterior hip or groin pain, stiffness, clicking, catching, or pain with flexion and rotation. Symptoms may worsen with squatting, pivoting, sitting, cutting, or positions combining hip flexion, adduction, and internal rotation. The exam may include Fader, Faber, hip range of motion, scour, log roll, squat, and lunge assessment. Positive special tests are not diagnostic by themselves. Interpret them with the full history and refer when symptoms are persistent, mechanical, or functionally limiting. Deep groin pain and catching should raise joint concern. Femoral neck stress fracture is one of the major do-not-miss conditions in this region. It often presents as gradual groin or anterior hip pain that worsens with running, impact, hopping, or weight-bearing. Early on, pain may improve with rest, but as it progresses, it may appear with walking or even at rest. Risk factors include rapid training increases, low energy availability, menstrual dysfunction, low bone mineral density, prior stress injury, and endurance sport participation. If you suspect this condition, stop impact activity and refer urgently for medical evaluation and imaging. In adolescent athletes, age changes the differential because growth plates and apophyses are vulnerable. Traction apophysitis or acute avulsion can occur at muscle attachment sites, such as the ASIS, AIIS, iliac crest, ischial tuberosity, lesser trochanter, or greater trochanter region. Mechanisms often involve sprinting, kicking, jumping, or sudden forceful contraction. Findings may include focal bony tenderness, pain with resisted muscle action, pain with stretch, a pop, or inability to continue. Do not treat a suspected avulsion like a mild strain. Refer for imaging when suspicion is present. A hip pointer usually refers to a direct blow over the iliac crest or surrounding soft tissue. Pain can be sharp, localized, and worsened by trunk motion, hip motion, running, or direct contact pressure. Assess swelling, bruising, gait limitation, bony tenderness, and the athlete's ability to protect the area. Also screen for abdominal symptoms, because direct trauma can be more than a superficial bruise. Management often includes protection, padding, symptom control, progressive motion, and return only when function and contact tolerance are restored. Refer for severe pain, abdominal symptoms, suspected fracture, or significant functional impairment. Hip, groin, and thigh symptoms can be referred from the lumbar spine, sacroiliac region, abdomen, pelvis, or neurologic system. Numbness, tingling, weakness, bowel or bladder changes, fever, night sweats, unexplained weight loss, constant non-mechanical pain, or symptoms unrelated to movement should increase concern. Inguinal or abdominal pain with coughing or straining may require evaluation for hernia or another non-musculoskeletal condition. Stay within scope. If the presentation is unclear, systemic, neurologic, abdominal, pelvic, or high risk, referral is the appropriate clinical decision. Rehabilitation and return to sport reasoning should match the tissue, irritability, severity, and sport demands. Early management focuses on protection, symptom control, restoring comfortable motion, and normalizing basic function. Later phases build strength, eccentric capacity, trunk and pelvic control, running tolerance, cutting, kicking, landing, and fatigue resistance. The key is progressive exposure. A soccer athlete must tolerate cutting and kicking. A sprinter must tolerate high-speed running. A jumper must tolerate landing. Return to sport should be earned through function, not assumed based on time. Early management begins by protecting the athlete from activities that worsen symptoms. That may mean modifying sprinting, kicking, cutting, impact, or contact. Use relative rest and load modification rather than complete inactivity unless the condition requires restriction. Restore comfortable range of motion, gait, and basic function while respecting tissue healing and pain response. Monitor swelling, bruising, pain, and guarding. Refer when red flags, suspected fracture or avulsion, neurologic symptoms, systemic signs, or diagnostic uncertainty are present. The clinical sequence is simple. Protect first, restore the basics, and do not rush speed. Strength and motor control progressions should move from low irritability work towards sport-specific demand. Early on, pain-tolerated isometrics or low-load exercises may be appropriate. Then progress to isotonic strengthening, eccentric control, multi-joint patterns, and single-leg tasks. Train the specific deficits: hip abductors, extensors, adductors, flexors, posterior chain, and trunk control as needed. Progress from bilateral to unilateral, slow to fast, linear to multidirectional, and controlled to reactive. Use the athlete's symptom response during and after loading to decide whether to progress, hold, or modify. Return to sport decisions should include symptoms, range of motion, strength, movement quality, confidence, fatigue tolerance, and medical guidance when relevant. The criteria must match the sport and position. A soccer player needs cutting, kicking, acceleration, deceleration, and reactive movement. A runner needs progressive distance and speed tolerance. A contact athlete needs contact readiness and protection. Return to sport is not one test. It is a gradual demonstration that the athlete can meet sport demands with acceptable symptoms, control, strength, confidence, and safety. In this soccer case, the athlete reports medial groin pain during kicking and cutting. Pain is reproduced with resisted adduction and palpation near the adductor origin. Failure is mildly uncomfortable, but not the primary symptom, and there are no systemic symptoms or pain with walking. The most likely category is adductor-related groin pain, but the differential should still include iliopsoas-related, inguinal-related, pubic-related, hip-related, and referred sources. Early management should reduce painful kicking and cutting, restore comfortable motion, and begin progressive adductor and pelvic control work. Refer if symptoms persist, worsen, or suggest non-muscle pathology. This runner case is different. The athlete has gradually worsening deep groin pain that now hurts with walking and hopping after a rapid increase in training volume, with a history of bone stress injury. That pattern must raise concern for femoral neck stress injury. This athlete should not continue running today. The safest step is immediate impact restriction and referral for medical evaluation and imaging. When explaining the concern, be clear. Deep groin pain with worsening weight-bearing tolerance and bone stress risk factors is higher risk than a routine strain, and continuing to load it could make the injury more serious. The key takeaway is that hip, pelvis, and thigh evaluation depends on location, mechanism, age, load history, and weight-bearing tolerance. Muscle strains are common, but they are not the only possibility. Groin, anterior hip, lateral hip, posterior thigh, and pubic pain each point toward different structures and different risks. Screen red flags early, especially femoral neck stress injury, apophyseal avulsion, neurologic symptoms, systemic signs, and non-mechanical pain. Return to sport must match sport demands, including strength, speed, cutting, kicking, landing, confidence, and fatigue tolerance. These references support the anatomy, terminology, red flag recognition, and clinical reasoning used throughout the lecture. They are included so learners can review groin pain terminology, hamstring injury guidance, femoral neck stress fracture considerations, anatomy, muscle testing, and broader sports medicine management. To close, remember that references are not just an end-of-slide formality. They help clinicians keep care accurate, current, and defensible. When a presentation is unclear or high risk, use reliable sources, document your findings, and refer appropriately.